So, my name is Ralf Eberhardt. I'm from Germany. I'm working in Hamburg at this moment, and I have done a lot of research about EBUS, EBUS TBNA, navigation techniques. And when you're looking to the lectures here at the Congress, you can hear about electromagnetic navigation, robotic assisted bronchoscopy, and so on. And Radial EBUS now is available for 20 years. And I think it's still one of the most important tools for managing your patients with an unknown primary pulmonary nodule. So in 2023, it's still a challenge to diagnose peripheral nodules because the nodules the patient will have in your unit get smaller and smaller, and there are some reasons. We have an increasing number. We have more and more CT scans which will be performed due to other reasons. And now we have also lung cancer screening programs. So 15, 20 years ago, a nodule was 3 or more centimeters. The nodule today is less than 2 centimeters, maybe only 1 centimeter, and you have to make a diagnosis. And this can be the reason why it's maybe difficult to reach by bronchoscopy. And then you can ask, is it really a friend or a foe when I try to diagnose this nodule by bronchoscopy? So what is the goal? The goal is normally to resect all malignant lymph nodes, but avoid any unnecessary surgical procedure due to morbidity and mortality or cost effectiveness. And maybe you can do also a radiotherapy, but you only want to treat the malignant nodules, and therefore you need a diagnosis. You have to confirm that it's really cancer, and so you have to take a biopsy. You can say, okay, I will send all my patients to the surgeons. He will cut it out, and then I know the diagnosis, and I have the therapy at the same way. But there are some reasons why you need a diagnostic before referring the patient to the surgeons. And first is the patient wish to confirm that it's really cancer before somebody takes a surgical biopsy or resection. Maybe you have a benign disease, tuberculosis, granulomatosis, or something else in your mind. And I think the most important reason is that you have patients with a lot of comorbidities, and a majority of your patients are not candidates for a quick surgical procedure. So these are the reasons why you can try to make a diagnosis bronchoscopically. I have one patient example from Hamburg I have seen this year. It was a 59-year-old male, COPD moderate. He has a hypopharynx carcinoma 2 years ago. He was a smoker, and now he has this nodule, 12 up to 18 millimeters in the right upper lobe. There's no bronchosign in the CT scan, and it's suspicious of lung cancer maybe or metastasis. We don't know it. For this reason, we try to perform a diagnosis. And now the question is, what can I do? The routine method, and I think this is still the routine method in most of the centers who are doing diagnostic bronchoscopies, is fluoroscopy combined with transpharyngeal biopsies. And there are some disadvantages. First, the radiation load, it's lower than with cone beam CT, yes. But the diagnostic yield directly depends on the size of the nodule. Is it a large size? It's very easy. Is it smaller? It gets more difficult. From the location, the relationship between the nodule and the airways, which biopsy instrument you are using, you can use a peripheral needle, you can use a forceps, you can cryoprobe, and at the end, a little bit from the experience and the skills of the operator, and sometimes you need also luck. When you're looking to the literature, it has not changed in the last 10 years. You can diagnose 1 of 3 nodules if it's less than 2 centimeters, and maybe 2 of 3 nodules when it's more than 2 centimeters. You can increase your yield if you combine it with peripheral transponction needle aspiration. I think you can increase it also if you are using a cryo probe. But what are the requirements for a successful biopsy in your daily routine? First, with your instrument, you have to reach the periphery of the lung. So you can use an ultrasound bronchoscope. You can have an extended working channel, which is placed in the peripheral lung if your bronchoscope cannot reach. Or you have a roboter in your hospital and in your endoscopic suite, and you do robotic bronchoscopy. Then you have to navigate because a solitary pulmonary nodule is defined that is not visible endoscopically. So you can try and error. You can look to every subsegment, or you can use fluoroscopy with all the disadvantages. Maybe you can plan a pathway when you are using virtual bronchoscopy before, or electromagnetic navigation is also possible with and without fluoroscopy to navigate to the target. And at the end, you have to confirm that you have been able to achieve your target. And maybe if you are using an ultrasound bronchoscope, it's endoscopically visible. Or you can use cone beam CT. Cone beam CT is an excellent tool to confirm that you have reached the lesion or not, but it's not a navigation tool. This you have to have in your mind. And I think the simplest way is to use Radial EBUS. So these are the different guidance techniques which are available nowadays. We have still fluoroscopy, we can use virtual bronchoscopy. This is very common and this is really cheap. It gets more expensive if you're doing cone beam CT or maybe electromagnetic navigation or robotic. And the Radial EBUS is one of the tools you can combine with all these technologies. You can combine it with robotic as well as fluoroscopy only. So Radial EBUS is one of the main tools or the most important tools because it's the only one which can confirm that you really have achieved the target and that you have the chance to get a positive biopsy. So what are you doing? You stick it like a forceps in the peripheral lung. If you have reached the lesion, the image will change from the snowstorm image to this solid lesion. You can see a small vessel at the margin of the lesion. And now you know, okay, I'm able to reach my nodule endoscopically. The diagnostic yield is excellent if you can place it within the lesion. It drops down if it's only adjacent, and it will be negative in most of the cases if you have no positive signal. So what about the yield, the diagnostic yield? It's around 75%. And this has not changed in the last 10 years because it's an established technology. You can see on the left side meta-analysis of 13. Now we have 47 studies about radial EBUS in peripheral lesions, and the sensitivity is still more than 70%. So you have to know when you are thinking, what will I buy for my endoscopic suite, or what can I do when I have a patient with a peripheral nodule? You know, EBUS guided TBB is a very easy and effective method. It's useful also in fluoroscopically invisible lesions. It can increase your diagnostic yield, especially in small lesions, less than 3 or less than 2 centimeters. And you can combine it with all these other technologies. But I think Radial EBUS is the base of diagnosing SPNs. And it confirms that you were able to reach the lesion. And the disadvantage, it's not a real-time procedure, so you have to remove it before taking biopsies. And it's not a navigation tool. You have to combine it with fluoroscopy, or you have to do it like try and error and be happy when you have reached it. But you can increase your diagnostic yield depending on the size between 60 and 75%, and you have no additional cost for your procedure itself. So this is the reason why Radial EBUS is recommended also in the guidelines when available, because you can confirm in real time the ideal location of bronchoscopic samplings. When I published about electromagnetic navigation 15 years ago, Gerald Silvestri asked in an editorial, should patients be referred to high volume centers only? Because these centers nowadays have robotic bronchoscopy, they have cone beam, they have electromagnetic navigation, they are doing it, they need 2 hour time for one nodule. So what should I do? I think that the majority of the centers have not access to this high end technology, and also the majority of the patients with unknown nodules have no access to these centers. So for daily routine, we need a very simple and effective method. And if you increase your diagnostic yield from 70 to 80 by combining all these technologies, you have to do it 10 times to have one more positive diagnosis. So this you have to have in your mind. So it's the question, is it still the same? Is it needed? Or is it a technology for maybe therapy, microwave ablation or something else in the future? So what do I expect from my guidance technique in daily routine when I'm doing it in my unit in Hamburg? So I want to improve my diagnostic yield. It should be a very easy and safe application and a short examination time. I have not the time to do a 2 hour procedure for one nodule. In this time, I have to diagnose 4 patients maybe. So it must be a very short and easy procedure. And the investment cost has to be as low as possible, and ideally no additional cost for the procedure itself. So if I have to buy a catheter for 1,000 euro for the procedure, I have to pay 10,000 euro for each positive diagnosis when I'm increasing 10% diagnostic yield. And it must be available. So we know, due to the relationship of the airways to the nodules, the diagnostic yield, independent from the technology, is limited to 70 plus up to 80% maybe. You will never reach 100% if you going endoscopically through the airways. And when I compare now all these technologies, then you can say diagnostic yield is high when I'm using one of these technologies. It's an easy application. Radial EBUS, yes. Robotic, maybe yes, if you have some experience. If you combine all these technologies, the diagnostic yield can increase up to 80, 85% maybe, but it's then more and more difficult. What about the duration? Radial EBUS is very quick, is very fast. Electromagnetic navigation normally less than half an hour. Cone beam, a little bit longer time. The longest time you need is for robotic bronchoscopy, or if you are combining all these procedures. The investment, for Radial EBUS, a mini probe costs 5,000 euro. Electromagnetic navigation is much more expensive for the console, and you have to pay 1,000 euro per procedure. A cone beam, you have high investment costs, but low procedure costs, only electrical current. And robotic also has costs for investment and procedures. And the highest price you have to pay is when you are combining all these technologies. This is the reason why some centers have everything, but this is not the reality in daily routine. And you have to think about, is it really necessary for my own unit? Coming back to my patient, this was the patient, 49 years old, with this nodule in the right upper lobe. We have done a bronchoscopy with an ultrathin bronchoscope. It's an external diameter of 3 millimeters. We were able to reach it. We confirmed that we have reached the lesion by radial EBUS and also fluoroscopy. And you see that the duration of the procedure was 21 minutes. The radiation time was only 14 seconds, and the radiation dose was very low compared to cone beam CT, for example, because you need just a few shots to know where you are. And the diagnosis was positive. It was a squamous cell carcinoma, and it was more favored to be a metastasis than a primary lung cancer. So in this case, we had a positive diagnosis by an easy and quick procedure with radial EBUS. These are the tools we are now available in 2023 in my hospital. We have this thin scope, we have the ultra thin probe, and we using small forceps or maybe ultra thin cryo probe to get more material. And when you're doing it in this combination, then you see the diagnostic yield will be also high in small lesions. There have been no significant differences depending on the distance to the pleura, bronchosign, localization, or operator. It's a very easy procedure, and the size of the sampling is much bigger or much higher than compared to forceps biopsies. So you have more material for molecular testing, for example. So what is my conclusion? I think that radial EBUS is easy to implement in diagnosing peripheral pulmonary lesions, especially also in your own bronchoscopic suite. Maybe you have an EBUS TBNA processor, or you will looking for one. The additional costs for radial EBUS are really low, and in my opinion, to confirm that you have been really able to achieve the lesion is the most important advantage of this technology, and therefore it's needed for a successful management. Thank you for attention, and I'm please open for questions. Yeah.
Thank you so much for the presentation. I just wanted to know, how did you manage the bleeding problems using the micro cryo probe?
So we know that the risk of bleeding, moderate bleeding, is higher when you are using a cryoprobe. We know this especially from diagnosing interstitial lung diseases. But we also know when we go forward with to the pulmonary nodule, and we are really inside the nodule, then the risk of bleeding is very low, because the risk of bleeding is when you're too centrally or when you freezing the vessels. If you are inside a nodule, you have not these big vessels for severe bleedings. So I think that the ultrasound cryoprobe is a real safe procedure, and especially in combination with radial EBUS, you can make sure that you are at the correct place, and therefore you have also not these high pneumothorax rates that you have when you're diagnosing interstitial lung diseases.
Do you use balloon for controlling the bleeding?
No. There's a recommendation of experts, we have written that when you're diagnosing interstitial lung diseases, you need a plan B when it starts bleeding. This can be a balloon blocker or a rigid scope. When you are diagnosing peripheral pulmonary nodules, I think the bleeding risk is not increased so much that I don't need a bronchus blocker, but I like to do it in combination with a rigid scope. So, no more questions? Okay, then
I've not understood. Do you use the rigid scope?
I spent 20 years in Heidelberg before I changed to Hamburg. So this is our standard approach for everything: valve placement, EBUS, TBNA, and also diagnosing peripheral lesions, combining flexible with rigid. It's a lot of comfort for the patient and also for the physician, but it's not needed. But I recommend, if you're doing, for example, cryoprobes or transbronchial biopsies, it's nice to have a safe access to the airways. So use an endobronchial tube or something else if you have no rigid available. Okay, thank you for listening. I hope you will enjoy the next booth lecture and you enjoy the Congress the next 2 days.